Well, hi everyone. I'm so happy to be here. I'm Alison Boyce. I'm a pediatric endocrinologist at the NIH, and I study FD-MAS. I love these type of patient events. They are literally my favorite part of my job, so I'm really happy to be here. So I'll be speaking on bone pain, and I'm really grateful for Dr. Brown for giving us a great overview on pain in general. I'm going to try to focus this talk more specifically on bone pain, and as that relates to fibrous dysplasia pain. So hopefully with the two of us together, we can do a pretty good job of covering all our bases. So there are many potential causes of pain and fibrous dysplasia, as Dr. Brown shared. So I was just going to go through a couple of the main ones that make this really complicated to try to distinguish. So we know fibrous dysplasia places patients at risk for skeletal deformities. Anytime the bone forms abnormally, we can put weight on and bears weight abnormally, that can lead to pain. So we see this through scoliosis, through leg length discrepancies, and other types of deformities. We can see hypophosphatemia due to FGF23 excess. This can lead to rickets, poor bone mineralization, and that can lead to kind of an intrinsic type of pain. We can see overgrowth of the skull. This can lead to nerve compression. It can affect the different structures in the nervous system. This can lead to pain. Arthritis is a particularly important cause of pain as patients age. This is quite common in fibrous dysplasia. And also, sometimes fibrous dysplasia just hurts. This is probably the cause we understand the least. We know that FD has abnormal tissue. We know that tissue is very active. There's a lot of areas of bone forming and being broken down, and there's a lot of thoughts that they may contribute to pain on its own. But again, the etiology of that we don't understand well. So these look like nice little distinct buckets that we can distinguish between, but the reality often looks more like this. Often there's not only one cause of pain. You can have orthopedic issues on top of metabolic issues, on top of functional issues, and sometimes when those issues coexist, they can feed on each other, and it can make this really difficult to tease out. As Dr. Brown shared some of this, and just to reiterate, there's a lot of complexity to pain in FD. In general, we don't see any relationship between the amount of FD someone has and the levels of pain that they report. So we have patients with severe fibrous dysplasia with no pain, patients with small amounts of fibrous dysplasia and very little pain. Also, neuropathic pain, so the type of pain that comes from abnormalities in nerve signaling, does seem to happen in a proportion of patients with FD. And in particular, the more neuropathic pain someone has, overall, they tend to report higher pain levels and worsening quality of life. So that's just another cause of pain to consider that needs to be evaluated for. So approach to evaluating bone pain, again, is complex, but there are certain elements that are consistent for everyone, no matter what your causes are of pain. So on the blue side, those are things that should be done in any patient who has pain regardless of their disease. And again, as you've heard, the history is probably the most important element of this. So understanding the character of the pain, how it started, where it's located. Your clinician should also do a good exam, and for patients with fibrous dysplasia, this must include a musculoskeletal exam, looking at strength, range of motion, and how they're moving around. What type of gait abnormalities are we seeing? Imaging and labs are really important tools, particularly in patients with FD, but they have to be very individualized. There's no one-size-fits-all imaging or lab work that you should have done when you present with pain. So go through a couple treatment approaches, and as we've heard, corrective surgery is incredibly important, incredibly powerful, and is really essential component to managing pain. So this is helpful when pain is resulting from mechanical destabilization. So corrective surgery can prevent deformities from progressing and can prevent them from appearing in the first place. It's important for preserving function, decreasing fractures, but there's always a trade-off. Anytime you have surgery, you introduce a risk of having pain and complications because of that procedure or because of the hardware that's in place. And this is actually, this picture here is a patient with osteogenesis imperfecta, but I think it's just a nice example of surgery that's performed in a staged approach, which where you start with bowing deformities, and then we see at the end we have some nice straight stable femurs. The patient on the other side, we see fibrous dysplasia lesion, which didn't have any clear fracture to it, didn't have any clear bowing, but this patient had consistent pain with weight bearing. And as we heard from Dr. Malone, that often can be a sign that the femur is under stress and that a fracture might be impending. So in this patient, by stabilizing the femoral neck and placing an intramedullary rod, the pain disappeared. Now, when it's simple like that, it's often very satisfying. That patient clearly had pain from mechanical stabilization, and that's what needed to be done. But ruling that out is important because the last thing you want to do is treat a patient like this with a lot of unnecessary medication when what they need is a corrective surgery. Okay. I think physiatry is one of the most underutilized specialties in FD, and I think it's a really important component of controlling pain. So physiatry is sometimes, it's a field that suffers from a branding problem because it has a number of different names. Sometimes it's called physiatry, sometimes it's called rehabilitation medicine, sometimes it's called physical medicine and rehabilitation, or PMNR, but these are physicians who are residency trained, and they specialize in function. So in patients with fibrous dysplasia, they're very helpful in looking at gait, seeing how people walk, how they move. They're helpful in identifying assistive ambulatory devices, so what are the appropriate crutches, wheelchairs, other tools. And they often work closely with physical therapists. So they'll typically be the ones assessing muscle function and prescribing specific physical therapies to perform. And the reason this is important is because we know there's a very close relationship between the muscles and bones. Both tissues send signals back and forth to each other. Strengthening muscle is really important for strengthening bone and vice versa. It's really important for core strength. Sometimes when a patient will have pain in their feet, in their hips, we can tend to focus so much on the lower extremities, but this can be impacted by the whole body. So this is a patient with really poor posture. It's probably 80% of kids in a 5th grade classroom are going to look like this. So they're slumped over. You can see the neck is flexed, the head is tipped back, the pelvis is tipped, leading to tightening of the hips. The heels are lifted. This is a sign of a patient that has a weak core. If you strengthen the abdominal muscles, sometimes that entire posture will improve, and it can actually help with muscles and gait and range of motion in many areas. So physiatrists are really clued into these type of issues. Also, in fibrous dysplasia, I think alignment is just so critical. I mean, your body is built to bear weight symmetrically because, as Dr. Malone shared, we know that fibrous dysplasia can overgrow, leading to an extra long limb, but also because of bowing and because of surgeries, you can also end up shortening the limb. So it's pretty common to have leg length discrepancies. And when you're bearing weight abnormally, it puts extra stress on the hip. Because your body is built to want to keep your head straight, you will tilt your shoulders, and that puts extra strain on the spine. Because the underlying bone is so soft, all of these things increase the risk for developing deformities. At NIH, we recommend shoe lifts quite frequently, and even in patients that have leg length discrepancy as small as a centimeter, we tend to use a shoe lift. I sometimes get pushback from orthopedic colleagues or physiatry colleagues on the outside that are not so concerned about those small leg length discrepancies, but I always try to bear in mind fibrous dysplasia is softer than typical bone, so we have to have a higher threshold of trying to line people up straightly. Positioning in wheelchairs is really important. Wheelchairs can be difficult to get, and ideally it should be positioned individually for you to make sure we're not putting extra stress on the back and hips. So medication for bone pain, and this is where we use a stepwise approach. So for mild pain, we tend to start with NSAIDs, with acetaminophen, kind of standard medications. However, if pain is moderate to severe, and it is persisting more than 3 months, then we tend, and we've ruled out orthopedic causes, that's when we would consider using bisphosphonates. So zoledronate, pamidronate, and this is plus or minus some of the adjuvant treatments that Dr. Brown shared. So bisphosphonates are a type of medication that tries to mimic a bone protein called pyrophosphate. It essentially tricks the body into taking the medication up into the bone, and once it gets into the bone matrix, it inhibits osteoclasts, or bone breakdown cells. Because it's incorporated into the skeleton, it has a very long half-life, more than 10 years. And this is basically how it works. So we know that bones are constantly cycling. We have, they're being built and up and broken down and built up and broken down all of the time. And that's how they stay healthy and alive. Osteoclasts are the type of cell that chew the bone up. And then osteoblasts are the bone building cells that go in and fill in the holes created by the osteoclasts. So bisphosphonates are targeting these osteoclasts. They're trying to stop the bone from being broken down. So that's why the most common reason for them to be used is patients who have low bone density, like osteoporosis, trying to help them build more bone. That's not what we're trying to do in fibrous dysplasia, but we can sort of capitalize on the fact that they have a similar action. So how do bisphosphonates treat pain? This isn't something we completely understand, but there are a few ideas. So we know that osteoclasts can communicate with nerve cells, which they have acid-sensing channels, and by decreasing the activity of those, we can reduce the nerve signaling into the bone. Also, these nerve cells will decrease their production of inflammatory cells, and it's thought that this might reduce inflammation in both the brain and the nerves in the body, which can reduce the sensation of pain. So there's at least some evidence to suspect that the bisphosphonate alone may be helpful for pain sensation. So in the 90s and early 2000s, we were so excited about bisphosphonates in FD because we thought that by decreasing these osteoclast activity, we might be able to improve the bone quality. But unfortunately, that doesn't seem to be the case. There's no evidence that giving bisphosphonates will change the formation of the FD lesion. It won't stop the FD lesion from expanding. And in one study, here on this side, you can see that a group in Montreal did bone biopsies of FD lesions before and after bisphosphonate treatment, and we don't see any change in the thickness of the bone and the amount of mineralized tissue there. Also, there are potential side effects to think about with bisphosphonates, and probably most notably for our FD patients is osteonecrosis of the jaw. And I won't go into that because we heard earlier from Dr. Burke about this side effect. But by putting all of this together, the current evidence only supports using bisphosphonates for pain relief. There's no evidence to support that it will have any beneficial effect on the lesion itself. So because of that, we want to tailor our treatment to using the lowest dose that we can get away with and the longest interval we can get away with. So you don't want to just have someone put on a set schedule the way you would for osteoporosis. And I'm not going to go into details here, but I just wanted to share that I lifted this table from the 2019 consensus guidelines, and I think this is something that can be very helpful for clinicians. We made recommended starting regimens for doses and frequency of bisphosphonate treatments for treatment of FD-related pain. Because again, you don't want to just sort of thoughtlessly put someone on this medication. You want to try it out, assess the response, and then figure out how frequently you need to give it from there. So what about, are there any other ways we can target osteoclasts? So rankle is another protein that controls this balance between bone formation and bone resorption. And then just like bisphosphonates, if you give a medication to inhibit rankle, you can target the osteoclasts and try to break this bone remodeling cycle. So is this a potential way we could try to improve bone pain in FD? So denosumab has been shown to be, unlike bisphosphonates, does seem to impact activity of the bone lesions. So when we give denosumab, we see a reduction in bone turnover markers. So those are products the body makes when the FD lesions are very active. We see they decline quite a bit. We see a reduction in FD lesion activity on bone scans. So this is a sodium fluoride PET CT, which you may have heard about in an earlier lecture. This is a scan that allows us to really measure how much activity is going into the lesion. And with high-dose bisphosphonate treatment, we see this activity decline. In this study, we saw improvements in pain scores and improvements in physical function. So this was all very encouraging results. So in this study at NIH, we did FD lesion biopsies before and after giving denosumab, and unlike bisphosphonates, we saw some pretty big changes here. So denosumab treatment will increase the formation of bone within the FD lesions, as you can see here all by that dense pink stuff at the bottom. I wish this pointer worked. Yeah, it's not going to work. So at the lower left corner, you can see before bisphosphonate treatment, the lesion is just very pink and purple, and that's just a lot of fibrous tissue. The bottom image, you can see that kind of denser, smoother pink stuff coming in. That's mineralized bone forming on top of it. We looked at expression of cell proliferation markers. So all of the brown dots in the middle panels are a protein that cells make when they're dividing a lot and making new cells. And we see that that goes down quite a bit with denosumab treatment. And then we see increased expression of proteins that are responsible for making more bone. So when we put all of this together, it seems that denosumab is decreasing the turnover of these fibrous dysplasia cells and making more bone in the lesion. So that's all, all very exciting. The downside to denosumab is, unlike bisphosphonates, it does not have a long half-life. In fact, it has an extremely short half-life. And its half-life is different in every individual. And frustratingly, the more active your bones are, the shorter the half-life is going to be. And that's frustrating because people with higher bone activity are really the ones that need denosumab the most. So we had a lot of trouble with this medication wearing off in our study. When it stopped, when patients are treated, their bone activity will go quite low. But when the medication is stopped, it will temporarily increase, even higher than it was before you gave the medication, before eventually settling out right about where it had been in the beginning. So in one patient who had probably the most severe FD, this rebound was so high that the patient developed high blood calcium levels that was really life-threatening and needed to be treated in the hospital. Luckily, this is something we could manage, and she did absolutely fine. But this is obviously a pretty serious side effect, even if it's rare. And this is a side effect that you're much, much more likely to see in patients who are younger and patients who have a lot of FD, which, again, are the patients who we most want to find a treatment for because have some of the highest treatment needs. Other safety issues. Denosumab can be associated with low blood calcium levels when you're taking the medication, and it's this at least in patients outside of fibrous dysplasia, has been life-threatening and even fatal in a few cases. So it's critical that anyone who takes denosumab also takes calcium supplements and is being seen by an endocrinologist or a metabolic bone specialist. It isn't something you want to get just from your general practitioner. Also, denosumab probably has a higher risk of osteonecrosis of the jaw compared to bisphosphonates. Another important side effect, which we don't quite understand, are what are the effects on normal bone. Patients who don't have a lot of fibrous dysplasia, when they take bisphosphonates, there are probably going to be increasing the bone density everywhere, including the bone density that doesn't have fibrous dysplasia. It's possible that might increase fracture risk in the long term. We just don't know. So denosumab for FD, where are we now? There's really exciting potential to improve FD lesion activity and composition and bone pain as part of that process. But blood calcium levels are really an important safety issue. So there's many important questions that still haven't been answered. We do not know which patients with fibrous dysplasia should receive this medication. It's not a medication for everybody, but it probably will be very helpful for some. How long should patients be treated? We know that you will not have any benefit from the medication unless you are taking it. So if we start it, we have to be prepared to continue it for a long time. And what dose? In the study results I shared, we used a very high dose, and we saw huge changes in only 6 months. That's a very short period of time for the skeleton to change. So one takeaway for us is that we can probably get away with a lot less denosumab than we used in that study, which is good. So denosumab at this point is reasonable to consider for patients with very severe morbidity and very severe pain who don't respond to conventional management, bisphosphonates, physiatry, surgery if needed. We want to start with those things. But if that's not effective, I do think denosumab could be a potential option. But we need to be very careful, particularly in patients who are younger and patients who have a lot of fibrous dysplasia. So further study needed, and that is particularly true in children. So bone pain and FD, kind of trying to pull all this together. I just want to reiterate, just as you heard before, that a multidisciplinary approach is really important. And this is kind of the approach that I take. So I would be interested to hear if people have other thoughts. But in general, I try to view chronic pain and fibrous dysplasia as needing a few essential components on the team. The first is a surgical specialist, whether that's a craniofacial or orthopedic. They're critical. You want to have a physiatrist or a physical therapist, and a pain medicine specialist. And then, however, as a metabolic bone specialist, I really view myself as the team leader of this group. And the role of the metabolic bone specialist is really to understand the different causes of pain, to help tease out the fact that we have to consider orthopedic pain, functional pain, metabolic pain, to really understand how those can overlap. So it's our job to work with medical and surgical specialists. It's our job to optimize bone health and metabolism. And a metabolic bone specialist should really be the person who's prescribing and managing the bisphosphonates. However, the pain management specialist is just as important, and they have a different role. Pain management specialists understand chronic pain, as you heard before, how it can change the way your body processes pain. Pain medicine specialists are the ones that can liaise with psychologists, with psychosocial specialists. They can assess for and treat neuropathic pain coming from an alteration to the nervous signals. And it's really important that they help prescribe additional pain treatments, either medications or non-medication treatments, that can help reduce the need for bisphosphonates. When patients respond beautifully to bisphosphonates, that's great, but I don't like to give those medications every 6 months for 10 years. I like to see if we can add other elements to our treatment plan. Maybe we can get away with a bisphosphonate every 9 months, every 12 months. The further we can stretch it out, the longer we can use that medication. So thanks very much for your attention. I think we have time for questions.
Well, thank you very much to both of you. That was really important talks. It sounds wonderful with a pain specialist and the other person I can't even pronounce. What's your experience with the availability of this? Because in my country, they are very far between, and they have like 2 years waiting list for people with really severe neuropathic pain.
Yeah, it's been difficult, particularly with the opioid crisis here in this country. It's actually decreased the availability of pain medicine specialists, so it's challenging. I think you probably have a comment as someone who has filled that role.
Yeah, so I would say, like I said, I'm not in the classic pain management specialist role, but I think that you can find people within your orthopedic practice who may be non-operative like myself, who can help not just with patients who have FD or chronic pain, but can help with managing. A lot of people are now doing ultrasound-guided education in their sports medicine fellowship or in other roles. And so looking for other people who can help in the community, not just from that classic role, maybe great. I think it might be really hard for some patients with higher severe disease burden, but for those with more maybe mild or more functional issues, that you might be able to find someone through the sports medicine world.
Thank you. I have just one follow-up question. In your experience, how many patients would you estimate would be beneficial of medicines that we usually would use to treat the neuropathic components of pain?
I think Dr. Javed and I worked on a series, and I think we saw neuropathic pain, at least in reviewing the registry, in about 30% of patients. But again, more likely as you get older.
You mentioned early in your talk about the different tests that doctors should do. I just wanted to point out that we have, based on the guidelines, we have a patient guide also widely available, which is you can see on the website of the Alliance as well as on the International Consortium, which is basically a flyer indicating what questions you can ask, are smart to ask your doctor, and what questions your doctor should ask to you. And then I just wanted to point out to the patients here.
Yeah, it's a great point. Thank you. It's all you, friend.
That is a loaded question.
Just briefly.
So I think that you might experience pain throughout the entire day, but there will be moments in the day that make the pain more elevated. Maybe there's a trigger that you might have, and it's kind of, how do you react to that? How do you respond to that? And so I think mindfulness is a huge way of saying, okay, I'm feeling something. can you tell yourself to take a moment to take a few deep breaths? My children, when they went back to school after the pandemic, they learned kind of counting, and they kind of would breathe in and out with their fingers, and kind of, this was something they were teaching, 5-year-olds. So how do we teach mindfulness kind of starting at a young age? But I think it's easier to learn techniques when you're younger than when you're older. But anyone can learn mindfulness. Anyone can learn how to manage pain. And again, that's not to say your pain's going to go away by being more mindful of it, but how do you let the pain affect the rest of your body? Is it affecting your sleep? Is it affecting your relationships with your peers, with your partner, with your children, with your parents? And so how can we learn tools that can make us better? Is it exercise? Is it breathing techniques? Is it yoga, massage, whatever it is that works for you? And I think like I said, it's a loaded question because it has to be so individual, and you have to really take that person into consideration.
Yeah. I'm glad you brought it up too, because it's something we talk a lot about, even maybe not in relationship to pain, is that I think for someone with fibrous dysplasia, it's just so important to have a really strong body awareness, to be in touch with your body, because that's how just learning what ways are safe for you to move, what type of activities are going to stress your bones or not. So we try to work on that very, very young. It's kind of one of the first conversations I have. And it's important for reducing fractures as well as reducing pain.
You and I talked once about sort of staggering denosumab use with bisphosphonates, and how denosumab kind of builds the healthy bone, and bisphosphonates could potentially be used to sort of fill it in. So if there's just any experience with that, or if it's mostly just theory for the moment.
Yeah, no, that's a great question. And I think one of the most important ones that we hopefully need to work to try to answer is that there's been a lot of work in bisphosphonates in FD, and it's quite clear that they don't improve bone quality. The reason for that might be, it's possible that bisphosphonates, because they need to be incorporated into a bone matrix, fibrous dysplasia does not have very good bone matrix. So it may be that they're just not getting in there. But if you treat someone with denosumab and you form that mineral within the fibrous lesion, is it possible that giving someone bisphosphonates then will allow it to incorporate into the lesion and both maybe help decrease the rebound, maybe allow us to get away with less denosumab? I think it's a really important question. I know Dr. Romanucci is working on that in her mouse model, and it's something that I think clinicians are trying to understand just as in their daily use of denosumab and bisphosphonates. But we really do need systematic studies to answer that question. What makes this difficult, I think it's always important for us to bear in mind when we're studying a disease that has such a broad spectrum, is there is a huge range of patients with a huge range of disease severity, and what applies to more mild patients may not apply to the more severe patients. And we have to also bear in mind where is the biggest treatment gap. Again, there's a treatment gap for everyone, but it's probably largest with more severe FD. So we have to make sure that we're trying to be respectful of that too when we do these type of analyses.
I'm a hypnotherapist, and so I don't really have a question. I'd just like to say that I believe that hypnotherapy should be part of every pain management program. It's not suitable for everyone, but I know there's good research evidence on its effectiveness with people with arthritis and fibromyalgia, not just initially, but in a 6-month follow-up as well. I got interested in hypnosis as a child, my experiences of pain, and I was aware if I altered the state of my consciousness, it would affect the levels of pain I felt. So when I was an adult, I trained as a hypnotherapist. And I found it really effective. I mean, I've had 10 operations. Since 2009, I've used self-hypnosis to get off the painkillers as quickly as I can. So if anyone wants to have a chat with me about hypnotherapy and how it can help them, I'm happy to speak to them. Anyone answer any other questions? Thanks.
Great, thank you for sharing that. Have you worked with hypnotherapists?
I haven't, and I don't know if in America it's really, there are a lot of well-trained. I actually wouldn't know of one to even look into. So any resources, I'd love to hear.
I've been recently diagnosed with FD, and I also have osteopenia, so in the spine. And I am on Fosamax for the pain. And is that going to have a beneficial or a negative effect on my osteopenia?
So are you asking if receiving bisphosphonates may benefit the osteopenia? It's possible. So these medications are absorbed by all of the bones. So often we think of that in terms as a challenge because often we're trying to treat the fibrous dysplasia bones, but it's possible that if your bones have a lower bone density, they may benefit from being exposed to some of these medications. So yeah.
Plus.
Yes, Dr. Brown mentioned a topical product, Terangel or Truman. I'd never heard of that and it wasn't on the slide. Can you tell me what
it's Voltaren gel. It's also known as diclofenac. It used to be only prescribed, and it's now over the counter. You can get it at Costco. You can get it at any pharmacy. It comes in, you might see it as Tylenol arthritic gel. It's an anti-inflammatory gel. It's best used 3 times a day, but you don't have to. It's not really one that's like an as needed. It really should be used kind of in a consistent. But if you have bursitis pain or post-op pain, it's more superficial pain. It'll penetrate into the superficial layers. It won't work for deep bony pain. But if there's other more superficial pain, it might be really helpful. It works sometimes well for knee arthritis, kind of that superficial pain.
Along those lines, I have a comment in that it's important to understand that when your bones are not normal, the alignment is not normal, your gait is not normal, then you're putting abnormal pressures on all the stuff that isn't fibrous dysplasia. Okay, all the soft tissues, the muscles, the ligaments, the tendons. And so a lot of the pain that we see, you should not automatically say, oh, it's because of the bone. And so a lot of the things that people prescribe ordinarily for the aging population who have lots of aches and pains as the body, gets older, those things work. Massage, deep massage, heat and cold alternating, local injections into the muscles or the tendons, normal treatment for bursitis with ultrasound. All of that stuff has nothing to do with fibrous dysplasia. It has to do with the body mechanisms not being normal and suffering from the fact that your mechanical systems are not working at an optimal efficiency. So don't just automatically say, oh, it's my bone pain. Okay, yeah, the crooked bones are causing more stress on the other stuff, but a lot of that other stuff can be treated with ordinary, everyday things that we do for everybody else that's getting older in the population.
Excellent points.
I was curious to see, you have a musculoskeletal exam as one of the main things, and then I was told that NIH has maybe up to 30 different things that they're looking at, and we talked about lab work to go off of. So is there a list of exams and lab work that we should be running? Because our biggest problem probably is that we don't know what we don't know. So,
Yeah.
And some of these physicians don't know, and so.
Yeah. So the consensus guidelines from 2019 include a specific list of tests that we recommend, and then I think you had commented that the patient care pathway also has a version that you can bring to your doctor, which is really designed to communicate these things most effectively. So at NIH, we see patients as part of a natural history study, so we collect extra things on top of what you would see in the pathway because our goal is to understand fibrous dysplasia better over time. So it may not, I don't know exactly how many things are on there, but it's probably not 30. It's probably a little less. We may get 30. Yeah, we can certainly talk about that.
I was just wondering to what degree, I think this is the neuropathic pain, is it a direct effect of GNAS? Is it a direct effect of GNAS activating transmembrane adenyl cyclases, such as cyclase 5, which seems to be involved in pain?
It's a great question. You should study that and tell us. Yeah, no, I think there's just a lot we don't understand about the intrinsic FD pain. I mean, the fact that it tends to get worse with age has always been very strange to me because that's when you actually have less G-alpha-S mediated constitutively active cells present in the lesion. There may be, and I know Anne-Marie and Chelsea are quite interested in this, some communication patterns with the nerve, between the nerves and the bone cells. There's likely a lot of elements here that we're not understanding. I think that's part of why we emphasize so much that there's not one treatment for the pain. Although if you can figure out the cyclase, maybe there will be one day.
Is it mostly related to the long bones, or is it also related to headaches and pain in the relates to the scalp?
Yeah, no, good point. And probably could have emphasized that more here, is that certainly headaches are an important aspect of pain and fibrous dysplasia. And I would say we probably understand that form of pain even less. We certainly tend to see probably a higher proportion of patients with FD have headaches than the general population. My suspicion is probably more have migraines as well. But I suspect it may not be as simple as, oh, there's a misfiring rate in this lesion. Headaches are just very complex, multi-system events. And at this point, we don't have any specific FD-related headache treatment. In general, headache specialists are quite good at thinking of pain as a complex topic and trying to approach it from multiple dimensions. So there's no, at least not that I'm aware of, there's no headache treatment that's contraindicated in fibrous dysplasia. And we've seen patients benefit from a range of therapies, from triptans to Botox to the CGRP inhibitors. Probably as many as benefited as haven't. I haven't been able to detect any consistent patterns. But I will say in general, most of us have not seen the headaches respond as well to bisphosphonates, and possibly to denosumab, depending on what type of skull pain it is. So it's a little disappointing.
You could just speak to whether people get sort of desensitized to pain over time, and then how that